My name is Gondi. I'm a radiation oncologist at Northwestern and the co-principal investigator of NRG-CC009. It's a really important study as it focuses on a brain metastasis population that we've never previously evaluated in a cooperative group setting. These are patients with small cell lung cancer who have developed brain metastases. And part of the reason why we've never studied them previously is because oftentimes small cell lung cancer patients are treated with prophylactic cranial irradiation, meaning their brains are treated prophylactically before they develop brain metastases. And many of our brain metastasis trials have included whole brain radiotherapy as one of the treatment arms. And as a result, they've been largely excluded. However, emerging practice is to not use prophylactic cranial radiation in these patients as much. And so we're seeing a declining usage of prophylactic cranial radiation, therefore a much higher incidence of brain metastases developing in our small cell lung cancer patients. But we don't know how to manage them. We have two effective treatments that we know work for them. One is radiosurgery, and the other is hippocampal-avoidant whole brain radiotherapy. So from that perspective, this Phase 3 trial, NRG-CC009, is meant to be a practice-defining trial on how to manage small cell lung cancer brain metastases. So some of the most common questions that our colleagues ask is it appropriate to treat patients with either radiosurgery or hippocampal-avoidant whole brain radiotherapy, the two arms? And part of the issue is that we'd really have limited data in a prospective randomized trial to understand which is the most appropriate regimen. And oftentimes, because of the limited data, various sites treat these patients off trial with one or the other of their preferences. However, what makes it difficult for individual sites to think about this trial is an understanding that there really is equipoise for this particular question and a lack of real clear understanding of what is best. And in that setting, it's important that we as a community embrace this trial and try to discuss it with our patients in a fair and balanced way. We really don't know what is the best approach. There are pluses and minuses to each approach, and there's an opportunity to really define that question in a very meaningful manner in this trial. From this Phase 3 trial, we'll be practice defining. So in one respect, we've always thought that small cell lung cancer brain metastases should be treated with conventional whole brain radiotherapy. But we've been able to mitigate the cognitive toxicity of conventional whole brain radiotherapy with radiosurgery, one of the treatment arms, and hippocampal avoidance with memantine during whole brain radiotherapy, which is the other treatment arm. So to determine which of these approaches best helps our patients will answer so many questions down the road in terms of how we should manage these patients. And importantly, because of the large size of this trial, it enables us to recognize the upshot may not just be a one-size-fits-all picture. It may actually be an individualized treatment, and by having a large study such as this one, we may be able to better estimate and evaluate maybe there are differences and benefits by certain patient subsets to be able to better serve our patients over the long term. The next step for this research is to recognize that there's more than simply number of brain metastases or type of brain metastases that helps determine what is the best outcomes for our patients. We have two very effective modalities, radiosurgery, hippocampal-avoidant whole brain radiotherapy. And as we run this trial, along with a sister trial, NRG-BN009, also radiosurgery versus hippocampal-avoidant whole brain radiotherapy for recurrent brain metastases, at the end of those trials, we'll have up to several hundred, maybe up to 500, 600 patients who we can combine and look at their biospecimens, their imaging. We can look at various aspects of their cytokine profile or ApoE genotyping. All of these radiogenomic predictors of cognitive outcomes to really better understand what will optimize outcomes for our patients, not just in terms of survivorship, neurocognitive outcomes, but also their quality of life. So anything else that physicians need to know about this study, This is an exciting trial that will help define practice and is really hitting an inflection point. This study was activated right in the middle of the pandemic, when clinical trial offices all across the country were losing resources, understandably. But now the clinical trial offices are picking up. We've seen this trial activated at 40 sites just in the past 1 year and has enrolled 13 patients just in the last 3 months. We're at that inflection point. We've crossed the quarter threshold and we're starting to pick up accrual. This is a great time to get involved with the study, enroll patients, and become a significant contributor to what will eventually define practice in the future.